Hi, this is Dr. Calkins, and I'm going to be doing the wrap-up video on respiratory diseases, including influenza, pneumonia, restrictive lung disorders including pleural effusions, empyema, and atelectasis, and restrictive lung disease including pulmonary edema and pulmonary embolism. The first thing we're going to talk about is influenza. Influenza is a highly contagious respiratory disease. Most deaths from influenza occur in patients over the age of 60, and people at greatest risk have heart and lung disease. Assessment findings are usually minimal with normal breath sounds and uncomplicated cases, and symptoms often subside within 7 days. Common complications of influenza include dyspnea, crackles, the development of pneumonia, or they can also get ear and sinus infections. Diagnosis by health history, physical assessment, and knowledge of flu in the community. The viral culture was once considered gold standard, but they have decreased in popularity with the new rapid tests. Rapid tests, however, are usually most accurate when used within the first 48 hours of the onset of symptoms. Unless a patient is at high risk or develops complication, supportive therapy is often all the patient needs, such as rest, hydration, analgesics, and antipyretics. Antivirals can shorten the duration of symptoms and decrease the risk of complication, but those too are have the best results if they're started within 2 days of the onset of symptoms. Flu season begins in September and continues through April, and it peaks usually between December and February. The flu vaccine changes every year since the most prevalent strains of flu tend to change every year. This is also the reason why you can still get the flu if you get the flu vaccine, because there's so many different strains of influenza. It takes about 2 weeks for immunity, so it's best if you get the flu vaccine at the beginning of the flu season, but there's still benefit of getting it any time during the season. One of the most important reasons why us as healthcare providers get the flu vaccine is to decrease the risk of transmitting the flu to others. Although you and I may end up with the flu and do relatively well with it, our patients that we take care of are usually elderly and have other comorbidities, which is going to increase the likelihood of them developing complications or morbidity or mortality from a bout of influenza. Next, we're going to talk about pneumonia. Pneumonia is an acute infection of the lung parenchyma. It is caused by bacteria, virus, funguses, and parasites. Risk factors for the development of pneumonia include patients older than age 65 or children less than 4, bed rest or immobility, post-op, altered level of consciousness, or difficulty swallowing. The most common presenting symptoms are sudden onset of cough, fever, chills, dyspnea, increased respiratory rate, or pleuritic chest pain. Typically, diagnosis is done with the chest x-ray, which shows the patterns and characteristics of infecting pathogens. This can a lot of times determine what type of pneumonia we think our patient is suffering from. For example, a right lower lobe consolidation has a high probability of being aspiration pneumonia, since the right main bronchus sits a little bit higher than the left bronchus, and a lot of times if we aspirate, it's going to go down into our right lung. We also want to get a sputum culture and gram stain on our patients, because that is going to identify the pathogen that's causing the infection. It's important that we get the sputum culture and gram stain prior to antibiotics, because once the antibiotics are given, it can affect the bacteria that's causing the infection. We're also going to want to get a white blood cell count, which won't diagnose pneumonia, but it'll give us an idea of the infection and whether it's getting better with treatment. We may also get blood cultures if our patients are really sick, to see if it's crossed over into the bloodstream. We're also going to get arterial blood gas on our patients. Not that that will diagnose pneumonia, but it will tell us how well our patients are oxygenating even with having the flu. We know a complication of pneumonia is airway obstruction and impaired gas exchange, so we're going to be wanting to make sure that our patients are having good, adequate gas exchange. It's really important that we start our antibiotics within 6 hours of hospitalization. We know that antibiotics are going to be needed to help treat our patients. We know that a sputum culture is going to take hours to days to get the results back. So what happens is we start the patients on a broad spectrum antibiotic for the type of pathogen that we think is most likely causing the infection. Once we get the sputum cultures back, we may have to alter the antibiotics to make sure that they are on the best treatment for the organism causing the infection. Other treatments include hydration, either orally or through IV. We want to make sure that we keep our patients thin, or patient secretion thin, because we know that airway obstruction is a potential complication. The thicker that the sputum is, the more likely that they could have a mucus plug causing an airway obstruction. So we want to keep those secretions thin so they can cough them out. We may need to give our patients oxygen if they're hypoxic, or analgesics and antipyretics to keep them comfortable. Nutrition is also going to be important, and it's going to be important that we provide our patients with small meals. Weight loss can occur due to difficulty eating with shortness of breath, and our patients are going to have increased metabolic needs because of the infection. We should see clinical improvement within the first 3 to 5 days of onset of symptoms, and to know whether our treatment for our patients is working. We'd expect to see their white blood count improving, their fever going down, their lung sounds improving, and their oxygenation getting better. Prevention of pneumonia includes receiving the pneumonia vaccine, yearly influenza vaccine, as well as hand hygiene and cough etiquette. Restrictive lung disease is going to include pleural effusions, empyema, and atelectasis. Restrictive lung disease are disorders that impair the ability of the chest wall and diaphragm to move with respiration. This is going to include pleural effusions, empyema, and atelectasis. Pleural effusions are not a disease but a sign of a disease. It is the abnormal collection of fluid in the pleural space, and it can occur with heart failure, pancreatitis, and pneumonia. The signs and symptoms that we're going to see is progressive dyspnea, absent or distant breath sounds, and the treatment is going to be a thoracentesis, and we'll talk about that later. Empyema is also a collection of fluid in the pleural space, but this is purulent fluid, so there's an infection that's going on with these patients. Typically, the cause is going to be from pneumonia, tuberculosis, or a lung abscess. The signs and symptoms are going to be similar to that of pleural effusion, except for because this is an infection, your patients are also going to have a fever. They might have night sweats, cough, weight loss, and I would expect them to have an elevated white blood cell count because of the infection. The treatment is going to be the same as with pleural effusions, except for our patients are going to need antibiotics to clear up the infection. Atelectasis is obstruction of the small airways with secretions, and this can occur because of pneumonia in our bedridden patients or in our patients who are post-op. Typically, you're going to see signs and symptoms of dyspnea, crackles, decreased or absent breath sounds. Typically, the crackles with atelectasis are going to clear when they do coughing and deep breathing or use of the incentive spirometer. We want to treat the cause, so if it's immobility, we want to get our patients up and ambulating, sitting them in the chair, having them use the incentive spirometer, and coughing and deep breathing. This is a picture of atelectasis, and so in the first one, you're going to see what a normal bronchial and alveoli look like. In B, you see as that mucus plug is starting to occlude that airway. And then in C, you have collapse of the alveoli due to atelectasis following absorption of the air. In this picture, you can see a picture of pleural effusions and purulent fluid with the empyema. Typically, the pleural space has about 10 to 15 mL of pleural fluid in there to help lubricate the lungs with inspiration and expiration. But what happens with these different disease processes is there's going to be a buildup of that fluid. If we get, if there's like 250 cc's or less, the body will eventually reabsorb it. But if it becomes greater than 400 and these patients have difficulty with breathing, they're short of breath, they cannot oxygenate, they need to require oxygen to maintain their SATs, then we may consider doing a thoracentesis on our patients. This here is a picture of somebody having a thoracentesis. We have them sitting on the side of the bed, and they're kind of leaning over a bedside table to open up their ribs so we can insert the needle into that pleural space. We're going to be draining fluid. We want to be careful not to drain more than like a liter or a liter and a half, because that could actually put the patient into pulmonary edema by changing the interthoracic pressure. But we're going to want to, one of the things is the needle should just go into the pleural space. If it goes through the pleural space into the lung, we could actually cause a pneumothorax with our patient. So we're going to want to make sure that we get a chest x-ray after we do a thoracentesis to make sure that we haven't collapsed the lung. We'd also be looking for them to have signs of increased respiratory distress, tachycardia, hypoxia, or things that would indicate that we have collapsed the lung and they're having difficulty with their respirations and their breathing. Next, we're going to talk about vascular disorders, including pulmonary edema and pulmonary embolism. Pulmonary edema is abnormal accumulation of fluid in the alveoli and interstitial spaces. It manifests as shortness of breath, hypoxia, crackles, increased respiratory rate, orthopnea, or difficulty laying flat, breathing with laying flat, anxiety. They may be cyanotic and coughing up frothy, blood-tinged sputum. Pulmonary edema is considered a medical emergency and can be life-threatening if we cannot oxygenate our patients. These patients may need to go to the intensive care unit for frequent monitoring, like a continuous pulse oximetry. They may need high flows of oxygen, and they may possibly need to be intubated until we can offload some of that fluid and help decrease their oxygen and gas exchange. Looking at these chest x-rays here on the screen, the one on the left is normal, and the one on the right, you see the diffuse white patterns, which is indicating pulmonary edema. If we had somebody who has pneumonia, we're going to see a consolidation in one of the lobes, either the right or left lobe, or the lower lobe or middle lobe. It's going to be located to a certain region and not that diffuse pattern or all over the lung spaces like with pleural edema, or pulmonary edema, excuse me. So whenever we have patients who have too much fluid, we always need to offload that fluid, and we do that by giving them diuretics. Looking here, you can see several different causes of pulmonary edema. One of the most common causes is going to be heart failure and overhydration with IV fluids. This is why it's so important when we're fluid resuscitating our patients that we're listening to their lung sounds before and during treatment, so we can quickly recognize if we're giving them too much fluid and they're becoming overloaded, so we can stop the fluids and give them diuretics if necessary. We can also have pulmonary edema if we have malignancies in the lymph system, if we have changes in interthoracic pressure, which can cause the fluid to kind of rush into the lungs, causing that pulmonary edema. Next, we're going to talk about pulmonary embolisms. Pulmonary embolism is blockage of one or more of the pulmonary arteries, and this can be caused by thrombus, fat, air embolus, or tumor or tissues. This picture shows several PEs within the lungs, and you can see beyond the PE where there's areas where we're not getting blood flow, and those areas are at risk for developing tissue or lung necrosis. The size of a clot is going to determine the extent of damage and the likelihood of death. Risk factors for developing a PE include, think back to Virchow's triad, anything that causes stasis of the blood, like immobility, obesity, or pregnancy, anything that increases the viscosity or thickness of the blood, like oral contraceptives or smoking, or endothelial injury, like surgeries, IV placements, or any kind of trauma. Signs and symptoms of a PE are varied and nonspecific. They will also depend on the size of the PE. A small PE may go undetected or cause vague transient symptoms. A massive PE may cause a sudden change in mental status, hypotension, and feelings of impending doom. When we think about diagnosis, they may draw a D-dimer, which is not going to be diagnostic, but just tell us that we have a clot degradation somewhere throughout the body, meaning that there is a clot somewhere in the body. A CT scan is the most common test to diagnose a PE, and IV contrast is used to view the pulmonary blood flow and vessels. And an ABG may be done, and that also is not diagnostic, but it's going to show how well our patients are exchanging gas. Treatments, anytime we have a clot anywhere in the body, is going to be anticoagulants. You can see here the different types of anticoagulants that could be used. And we, again, just like with our VTE or our DVTs, we're going to have that overlap of therapy where we're going to have Lovenox and Coumadin, because it's going to take time for a patient to become therapeutic for their PT-INR and Coumadin, so they're going to need that Lovenox treatment until the PT-INR is therapeutic. If the clot is really large, we may have to give our patient fibrinolytics. Now remember, anticoagulants don't break up the clot, they just prevent a clot from getting bigger or any new clots from forming. The fibrinolytics are actually going to break up and dissolve that clot, but they do that not only where the PE is, but anywhere throughout the body, so there's a lot of contraindications for risks of bleeding. If the patient can't take fibrinolytics and they are hemodynamically unstable, they may consider doing surgery and doing a pulmonary embolectomy where they go in and surgically remove the clot. If the patient cannot take anticoagulants, they may have an inferior vena cava filter placed. This isn't going to prevent clots from forming or bust up the clot that's there. However, it will prevent clots from, like the legs, traveling up and lodging into the pulmonary system. Here are a couple pictures of the inferior vena cava filter. It shows where it's placed, and the one on the right is showing some of those blood clots that are getting trapped in the filter. And that concludes our respiratory disorders.